So as we know, pancreas is biologically a very stubborn organ when it comes to malignancy. We'll just look at, in brief, at a few of the trials which have shaped decision making in the treatment of pancreatic cancer. So for convenience sake, I have divided into systemic therapy and associated trials, radiation associated trials, and we'll also briefly look at operative trials at the end. So in 2004, the SPAC-1 trial actually brought up the use of fluorouracil as adjuvant therapy for pancreas. After this, the CONCO 001 trial compared adjuvant gemcitabine versus no treatment after resection in resectable pancreatic malignancies. So they found that so this gemcitabine soon became established as an adjuvant therapy agent, as there was improvements in disease-free survival and overall survival. The SPAC-1 trial in 2004, they randomized patients into two arms, where one arm had received chemoradiotherapy and the other arm had received chemotherapy. However, this study showed that the chemoradiotherapy had surprisingly adverse outcomes. So the 5-year survival rates were comparatively less compared to the chemotherapy arm alone. So in Europe, this trial led to the belief that there was no role of radiation after operation. Over a few years, maybe about more than a decade later, more and more trials are coming up which are showing the effect of chemoradiation. So this is the JASPAC trial in 2016 in the Japan adjuvant study group of pancreatic cancer. So the S1 agent was compared with gemcitabine, and as a primary endpoint, overall survival was analyzed. It was a non-inferiority trial. However, the S1 agent was actually found to have found to be better in terms of overall survival and relapse-free survival compared to gemcitabine, and also the patients who were on this drug was found to have a better quality of life on follow-up. The SPAC-3 trial from 2010 had brought out gemcitabine as a standard of care. It was compared against 5-fluorouracil leucovorin therapy regimens, and it was better tolerated with lower toxicity profiles, and hence it became a standard of care. And subsequently, the SPAC-4 phase 3 RCT in 2017 considered the addition of capecitabine to the gemcitabine therapy, and there was some improvement in 5-year overall survival, and this combination was considered to be a new and improved standard. So if you notice from SPAC-1 to SPAC-4, the improvements in overall survivals have been rather modest. But from here to here, there has been a dramatic improvement in overall survival. This is the Protige 24 trial. It's a French trial where the modified FOLFIRINOX regimen was compared against gemcitabine in an adjuvant setting in patients who had undergone R0R1 resection of pancreatic carcinoma. Patients were observed for a period of 6 months, and the FOLFIRINOX, the modified therapy, there was slow infusion of 5-fluorouracil was used, and the FOLFIRINOX therapy is rather difficult therapy to undergo. So there were a lot of fitness criteria which were set down before patients were selected for this arm. Performance status, the recovery from surgery, and multi-organ functions were all taken into consideration. So there was actually quite a bit of significant improvement when we look at disease-free survival and overall survival. There was some, the M-folfirinox group had over disease-free survival of about 21.6 months compared to 12.8 months in the gemcitabine group, which is almost double. There was also significant improvement when we look at the 3-year overall survival rates and 5-year follow-up, 5-year survival rates. So this was this new regimen actually gave quite good disease-free survival and metastasis-free survival benefit in the patients who were actually fit to undergo this chemotherapy regimen. However, on the flip side, it was noted that the patients had more manifestations of adverse events and toxicity compared to the gemcitabine arm. So, patients who are younger and who are fitter, to put it simply, are better benefited by M-folfirinox therapy compared to gemcitabine alone. So the SPAC 5F trial is another trial which sort of again derailed conventional thoughts. It was a multi-center phase 2 trial. So it again compared in borderline resectable pancreatic carcinoma. That is the important key here. In patients with borderline resectable pancreatic carcinoma, it compared the effect of immediate surgery versus short course neoadjuvant therapies. So all the previous therapies which were prevalent and looked into till then, they were all compared. And it was seen that in the overall survival, the neoadjuvant arms had higher and better overall survival rates, and the folfirinox arm had a maximum overall survival rate of about a median survival of about 84%. So this again was a point which made folfirinox sort of a standard in many major guidelines. So radiation therapy, the lab 07 RCT from 2016, about 442 patients were randomized into who received induction chemotherapy for about 4 months. And patients who had not progressed on this induction chemo, they were randomized into two arms where chemotherapy, including the gemcitabine, was continued, and another group received radiation with capecitabine. So here again, the survival was there was no real survival, and in patients in whom erlotinib, which was added, they also did not show any significant survival. But the interesting fact is, patients who underwent chemoradiotherapy, they had less frequent locoregional tumor progression or recurrences as compared to the chemotherapy alone. In this, as an ancillary study in this trial, the modality of using circulating tumor cells for detecting micrometastatic disease had come up as a promising prognostic tool. A SCALLOP trial in 2016, again in locally advanced unresectable pancreatic cancer, the efficacy and toxicity of gemcitabine-based radiation therapy and capecitabine-based chemoradiotherapy was compared. And again, it was seen that there was some benefit when it came to capecitabine, and even the quality of life was seemed to be a little marginally better in capecitabine, and the hematological adverse events were lesser in the capecitabine group. So this was the capecitabine was established as a preferred chemoradiation therapy partner. The CONCO 007 trial, a trial from Germany, had looked at patients with locally advanced or unresectable pancreatic adenocarcinoma. So here about 495 patients who had received induction chemotherapy. Some of these patients had received FOLFIRINOX, some of them had received gemcitabine. They were again randomized into two groups where again the chemotherapy was continued and radiation therapy. The primary endpoint was initially overall survival, but because of low recruitment rates, it was changed to overall resection rate after reassessment for operability. The R0 resection in patients who underwent surgery was higher in the arms which had received chemoradiation. Here again, preoperatively, these patients had received targeted chemotherapy to the tumor as well as the suspected lymph nodal basins. However, there was no difference in overall survival between the two arms. The pre-op-panc trial in 2022, it is again a Dutch multi-center phase 3 RCT. So here, borderline resectable malignancies and resectable malignancies, pancreatic cancers were recruited. And the main objective was to assess whether neoadjuvant chemoradiation therapy actually improves outcomes compared to upfront surgery. So here, on the graph A actually shows that there is, if you just compare upfront surgery versus neoadjuvant chemoradiation, surprisingly, it's a stark difference from SPAC 1, where there is a significant improvement in neoadjuvant in overall survival. And when we look at both resectable and borderline resectable malignancies patients in both the groups, when we compare the neoadjuvant CRT as well as the upfront operation, both these arms had shown some improved resection rates and 5-year overall survival rates. And when we look at all the baseline characteristics of patients, when we look at the overall effect of this chemoradiation therapy, the study seemed to favor this. And so again, this sort of again challenged the paradigm where operable and borderline surgery should be offered first. And again in the Alliance trial, here again the FOLFIRINOX the group was compared to the FOLFIRINOX group receiving hyperfractionated radiation therapy. So here the overall survival, the FOLFIRINOX alone group had 66%. And again, the FOLFIRINOX RT group had 47.3%. Again, this is again a contradicting study compared to the previous one. So, but the importance is as a neoadjuvant therapy option, FOLFIRINOX had shown definitive benefit in this study. So, metastatic pancreatic cancers again. From a very conservative approach to metastatic pancreatic malignancies, multi-agent therapies have come up, and in spite of the worry about adverse effects, multi-agent therapies have shown to have improved survival. And in MPACT study and in the Napoli 3 trial, where the Nalrifox trial and was compared with the nab-paclitaxel and gemcitabine. The Nalrifox arm actually had better tolerance, and the quality of life when we look at various aspects were actually better, and the patient seem to tolerate these multi-agent therapies, which again goes against the conventional thought of single agent or more conservative therapies. Extent trial in 2024, it looks at in patients with less than 5 loci of metastasis, this ablation therapies, metastasis directed therapies as an adjunct to systemic therapy was compared with systemic therapy alone, and there was again a significant improvement in progression-free survival in these patients. targeted therapies, a lot of studies have come up, but however, none of them really offer any overall survival effects. However, new avenues are being developed. Operative trials, when we look at operative trials, minimally invasive surgeries is the talk of the hour. When we look at distal pancreatectomy, the Leopard 1 trial from Netherlands had shown that minimally invasive, first shown that minimally invasive surgeries can be done with lesser blood loss within reasonable operative time and with comparable complications compared to open. And again, another study from Sweden, the LAPAP trial had actually shown that in minimally invasive surgery, the healthcare associated costs were paradoxically lesser compared to open operations. And the Diploma 1 trial, in 2023 trial, showed that the minimally invasive operation, especially when it comes to distal pancreatectomy, including malignancies, including RAMS procedures, the R0 resection and lymph node harvest rates are actually comparable and with comparable post-operative outcomes and functional recovery. So in 2017 from India, Dr. Pallamelu had published this plot trial where comparable results were seen while comparing open Whipple operation and minimally invasive. And in Spain, this PADLAB trial had also come up with comparable complication rates, but however operating time was found to be longer. Following this, in Netherlands, they have the most rigorous training systems from their lay labs training systems, where people undergo rigorous stepwise graded training for minimally invasive operations. However, in this Leopard 2 trial from Netherlands in 2019 was terminated prematurely because of higher rates of complication-related mortalities. The reason being probably the learning curve and the difference in skill levels of surgeons across multiple centers. So this is a trial from Japan which again addresses this problem. They also showed comparable length of stay as well as complications when comparing minimally invasive and open Whipple operations. This study 3 years later showed similar overall survival while comparing minimally invasive and open Whipple operations. Again, finally, when we look at the robotic, again we are in the initial stages of implementation. The Europa trial from Germany has actually shown higher incidence of grade B and C pancreas-specific complications and higher rates of gastric emptying and higher costs. However, future trials which improve techniques and efficiency will help to bring this down. This is an already study which is already done, which compares open versus minimally invasive, which contains both robotic and laparoscopic. Our final publication results are pending. These are all upcoming trials. Where enrollment is currently going on when to compare open versus minimally invasive. Summary: even though now new evidence is coming up as we see more and more trials, rethinking the paradigm of upfront operation, especially in borderline resectable malignancies, are to be considered. But more robust evidence will hopefully help to change this, and better treatment modalities with lesser adverse effects will always help to reach this point. New avenues of pancreatic cancer therapy in the form of checkpoint inhibitors are in development. However, pancreatic cancers are biologically considered to be a biologically cold tumor. And when we look at the operative side, MIS is fast becoming the standard. The problem being, in Whipple operation, the implementation of robotic is taking a little more time, even though most centers in India have reached proficiencies which are at par with international levels. Thank you.
Well presented, Dr. Anoop. I think this is a very important aspect, that the survival part is considered. Post-operative situations, systemic recurrence is more than that of local recurrence. So there are lots of trials also ongoing. Now, what my concern is, do you have any preferred standard line of chemo drugs as of now? In resectable cases, I think we have more of clear upfront surgery plus adjuvant chemo. That is clear cut, I think. But in borderline resectable, now also it's like neoadjuvant chemo followed by surgery. But that preferred regimen that we have to follow in the neoadjuvant part, I think with regard to FOLFIRINOX and gemcitabine, lots of trials are showing conflicting results, no? That is...
To be very honest, I am a little far from the whole chemotherapy aspect as a surgeon, but when we look at the patient profile, most of the patients who come to us with borderline resectable malignancies are really not fit enough to undergo a regimen containing M-FOLFIRINOX. So usually they go down the more conservative pathway of capecitabine, and even radiation results have been quite equivocal. We are really not...
Most of the studies are showing negative actually.
Yeah,
radiation.
yeah.
Radiation doesn't add any survival benefit also. I think only in locally advanced cases radiation was showing some benefit.
Yes.
In other situations, I think when you compare with gemcitabine plus radiation also, it doesn't show much advantage gemcitabine arm alone. Some of the studies was showing that.
Yes.
Any questions from the audience? I think it's a very relevant scenario. I think in future more of a personalized medicine would come up because most of the targeted therapies like RAS inhibitor, they don't show much of benefit as of now. Anyway, there are lots of scope for in this area.
There are a lot of those trials. I
Yeah,
went through as much as I could, but I couldn't really see any.
It's very broad. Lots and lots of trials. Because the patients come and ask you lots of questions also because of the survival benefit is shown as very, I think roughly around months, 2 years, no? So, I think.
Sir, I would just like to ask that what is your opinion regarding robotic surgeries in case of pancreatic malignancies?
Okay. I'm nobody to comment on that. I think people, Dr. Paul and Dr. Kalarasan are better suited. Personally speaking, I have not started doing that. We are in the transition phase of MIS ourselves. So I don't think I'm not the right person to comment on that.
Thank you so much, sir. It was a very elaborate and very nice presentation. Thank you.